Health, Dr. Raymer was appointed Senior Vice President for the Office of Health and Policy and Legislative Affairs in 2008. In your packet is a very detailed background of Dr. Raymer, but just a couple of points that I think is important for this audience to let you know of his background and why I think he is one of the best people that we could have to help facilitate this discussion. He is a diplomat of the American Board of Pediatrics and a fellow of the American Academy of Pediatrics with an undergraduate degree in biology from East Texas Baptist University. In addition to the many hats he wears at UTMB, he is a member of the Texas Pediatric Society, Texas Public Health Association of Governing Councils. He is also the chair for the HHSC Advisory Committee appointed by the governor in 2013. Dr. Raymer had a unique perspective to visit Washington in April of this year as one of the representatives of the America's Essential Hospital Group that visited with the White House staff and domestic policy folks in Washington to talk about the role of the Texas waiver. He accompanied folks from both the state of New York as well as California. One of the other things that I'd like to mention before we ask Dr. Raymer to the podium is that in Texas, we certainly are all about coordination of care. In RHP2, we take that, I think, a little bit further because in addition to coordinating care, we seem to also coordinate fashion. So I'm going to introduce to you my brother and seersucker, Dr. Ben Raymer.
Thank you, Craig. We did not plan this. It's just sort of the uniform when you live in Galveston to get up and go to work in your pajamas, and this is sort of it. Thank you for letting me participate in this. Systems of care are ingrained in most pediatricians because pediatrics first introduced the concept of the medical home. We have known for many, many years, literally several decades, that the coordination of care is extremely important for children, and particularly children with special needs. The concept actually is also rooted in the behavioral health world. We know that it is an organizational philosophy and framework that involves the collaboration across agencies, families, youth, the target audience is being served with the purpose of improving services and access. There are core values in that system in the behavioral health literature, as you know, with the concept being actually driven by the patient and our family themselves. It's community-based, and it's also culturally and linguistically competent. We've all had experiences in that. I received a grant from the Robert Wood Johnson Foundation to open a school-based mental health clinic. And it was located in one of the most diverse high schools in Texas. And the provider that I offered up was a white Anglo-Saxon male child psychiatrist. And we were very concerned because no one in the high school, or very few, were utilizing the services. Went back and looked at our demographic population. 1/3 was Hispanic, 1/3 was African American. There was probably 10% at least Asian, and the other Caucasian. So we chose a provider that did not resonate at all with the target population. And during the time of the clinic, he averaged seeing only a modest couple of patients a week. When we addressed that situation and offered up culturally competent and language-appropriate providers, we grew to over 2,000 visits a year. So it has all to do with how you structure your system of care. It's also extremely important to integrate that system of care by enhancing the linkages between primary care, specialty care, and the inpatient setting. And we know about the inpatient setting because there are financial consequences if we fail to do that now. Everyone responds to those motivators. But those of you in this room, I think your chief motivator is the patient themselves. I believe that you recognize the importance of managing chronic disease, engaging patients on ways to improve their care delivery by coordinating that care, that they make the most of the time, the things that they have, transportation and opportunities to visit their physician or healthcare provider. You also have to look at those individuals who are currently using our emergency services systems, whatever those are, whether they're calling ambulances to get to the hospital or simply using the ER as a drop-in place, and realize that there are opportunities to improve that service by providing, as you've heard already today, the right care at the right cost, at the right place, at the right time. We have to invest in those building blocks also to analyze what we're doing. One of my staff members always says, if you didn't write it down, you didn't do it. And I think that's one thing, even though for many people it's been a source of objection, you've got to have your metrics to know if the program is working. For a long time in healthcare, we've simply done things because they seem the right thing to do. So when you go to your doctor, what does he do if you have a backache? What does he do? First thing he does, well, we'll get an MRI. If it doesn't show anything, we'll get an MRI with contrast. You know what? That's the most useless test in the world. I have chronic back pain. Physical therapy solves that problem. You ought to go to physical therapy first, but we don't do that because it doesn't make money for people who own MRIs, right? So we've got to change the way we practice to evidence-based, and that's the reason we need this data. HHSC didn't just wake up one morning and say, we're going to make a barrier for you. That data tells us what the best systems are. It tells us what works. It's a way to objectively look at continuous process improvement and the performance of those systems. We should not be doing things that do not add value to this system. We also target, with an integrated system of care, the most vulnerable populations. That's already been done for you with your DSRIP projects. We are serving both the Medicaid and low-income uninsured populations, and we, as you can see from the data that was shown on our choice of projects, chronic disease and mental health are certainly the most highly targeted issues, and rightly so, because they are the ones who impact both our cost and our society's productivity the most. We try to provide a collaboration that hits all the points that are important for collaboration, using diverse organizations that are brought together in a new way. This is all about discovering new relationships and bringing resources to bear that allow teams of healthcare providers and community support systems to work together. It's about developing that team-based approach to care that many universities are now incorporating into their curriculum. In the past, we have simply graduated doctors in that building, nurses in that building, and allied health folks in that building, and at another university, social workers, public health workers, and an array of other administrators and managers. The move in healthcare now is to integrate all of those individuals into a learning experience together in their undergraduate and graduate years so that they can better come together in the community and spend their time working together effectively. And when you approach that, I think this graphic represents those communities of care extremely well. We must bring together providers, social services programs, governments, payers, and the life sciences all into this equation. And you say, why is the life sciences important? Well, because there are biopharmaceutical breakthroughs and biopharmaceutical needs in our community, medical devices and diagnostics. There's a whole array of public health services that needs to be involved in the DSRIP picture, and we have got to include several branches of government, not just one. I have as chair of the Health and Human Services Advisory Board, I have been most supportive of the sunset recommendations that offer an opportunity for HHSC itself to become more integrated so that the right hand knows what the left hand is doing, so that public health is integrated with the needs of HHSC's Medicaid program, so that they can also extend their reach into the various other services like Department of Aging and Disability Services, Department of Rehab Services. That's extremely important if we're trying to provide services to the chronically ill, to children, and to the mental health arena. It is extremely important that population health management really be our goal in this equation. And that's a term that you need to grow comfortable in hearing and understanding, because I think that single word is going to really define healthcare in the future. DSRIP then becomes a vehicle, if you would, for transitioning or transforming a fragmented healthcare system into an integrated, patient-centered population management system that will be able to incorporate the milestones that we have identified to improve that integration and patient care. I know that's a mouthful, but transformation always is. You don't get from point A to point Z quickly. It's a process. And some of you in this room have done that in a remarkable amount of time. I have reviewed the metrics, and on the occasion of going up to Washington, having an opportunity to speak with and discuss our projects in Texas with the domestic policy chief of staff, what an opportunity to say what Texas is doing. We have seen transformations here that transcend the health system. Let me give you an example. We ran into some problems in the provision of psychiatric services through telemedicine. We had the executive director of the Texas Board of Medical Examiners on board, working with the DEA at the federal level. It doesn't get much more collaborative than that, than having a state agency involved with a federal agency to address problems and work out solutions. They didn't tell us what we couldn't do, but they looked at it as an opportunity to find ways that we could serve this population. That's true transformation. And the true transformation that you're directing in your community is also something that is laudable. And I think this session of the legislature, as I spoke with members, it's clear and evident to them that we are accelerating patient safety and quality, that we're building bridges in population health management, and that we're recalibrating our workforce, retraining them to function differently in healthcare than we have in the past. And all that's good, by the way. You know, a good definition of insanity is doing the same thing over and over and expecting a different outcome. We've done that long enough in healthcare. It's time that we move beyond that and look at things that measurably work, that are evidence-based. These systems of care that we're going to be talking about today goes beyond patient navigation and care transitions with your DSRIP projects. We're all familiar with the roles of community health workers and the importance of seeking ways to eliminate barriers to health care. In one of our own programs 10 years ago, when we brought together community, I thought the biggest issue in our community was lack of insurance. What I found out was it was a lack of transportation. There was not bus service. I discovered there was no bus stop at our university hospital. Yeah, that's a good one, isn't it? There was no handicap transportation services, on and on. I mean, if you don't ask, you'll never know. So the benefit of the DSRIP project has not been in the final outcome to me. That will vary quite a bit. It's been an initial needs assessment of sitting down and talking to the people in your community and finding out what is a problem for them. So access is a problem that we identify at the grass tops, but the grassroots may tell us there are other things. Financial, cultural, psychological, transportation, nutrition. We have food deserts all over Texas. We have places that people live in housing subdivisions that they have no access to fresh fruit and vegetables or good sources of nutrition. Yeah, they've got a convenience store down the road at the local Valero that they can buy some honey buns. By the way, I love those, and they're 550 calories a piece. 550 calories, okay? If you've got somebody that needs to gain weight, that's a good way of doing it. But let me tell you, that's what many people live on every day, and that's what gets packed into kids' lunches if you're not looking. So we have to address those kinds of things, not to mention housing. Those are all issues that are on our plate now as healthcare providers. We used to not think of that. We teach our students about that now, those social determinants of health that are so important. There are some advantages with that. You know, if we are going to improve access to care, we have to promote the adoption of some of these assisting abilities. Healthcare services and all of those kinds of things have to be relooked at. There are also some systems of care that need to be integrated into this, and I'll mention those very quickly. You already know about the patient-centered medical home, so I'm not going to spend a lot of time on that. This can reduce both the cost of care and the cost of readmissions. We have competing forces right now. Our hospitals are still on a volume-based reimbursement plan, and so they get rewarded for everybody who comes to the hospital with asthma. So sometimes, and hospital administrators don't kill me, but sometimes you don't have the incentive to keep those patients out of the hospital. The incentive right now is structured to more the merrier because my bottom line will be better. So we have some opposing forces. We have got to get beyond that and get to the reward for keeping people healthy in these health systems. There has to be alternatives to address the lack of resources and the other issues that face the patient seeking medical care. And there are some technologies that are coming to bear that will help us do that. Telemedicine can easily be embedded in most of our outreach efforts to serve this hard-to-reach population that is still in rural Texas and in health profession shortage areas within large cities. Don't think that telemedicine is just designed for rural use. It is not. At UTMB, we have used telemedicine to reach prison systems throughout Texas, so has Texas Tech, for over 15 years, matter of fact, almost 20 now. And in the course of time, we are now seeing 120,000 telemedicine visits per year. Can you imagine that? We're delivering health care in a safe environment, and the results are excellent. We've done that also in what we call the free world setting, working with rural communities, working with inner city groups, working with school campuses, and telemedicine certainly provides that virtual embedment of healthcare services into the target audience. It eliminates the problems with distance and transportation. The Burke Centers in East Texas found that out years ago. They had lots of windshield time for psychiatrists, and now they have patient time by using telemedicine. It's convenient for patients. They like that. It's a useful alternative when resources are short. So it's something that we have been able to put together and use very, very wisely. Before I ask you to look at a short video, I just want to congratulate you on what you've done. This is going in the fourth year now of some real work. I was just thinking, I was listening to the talks earlier that, as I would put it, there are saints that walk among us. Those saints are people who place the needs of others before their own needs. They're people who creatively search for ways to transform the lives of vulnerable people. They're people who advocate increasingly for better ways to improve the health in our state. They're people who keep on reaching out and reaching in order for others and organizations and governments to not give up. They're the people who keep this issue in front of us. They teach others. They overcome and remove barriers. They improve the quality of life of Texans. Most importantly to me as a pediatrician, they keep families together rather than apart. And most importantly, those kids grow into healthy adults. That's what your work is really about. There are saints among us who are kind, and they transcend our understanding about the care of Texans. I congratulate you on what you've done, and I really look forward to joining you to hear how other communities have done it. This is a great example in Childress, Texas, of bringing resources together through collaborations for transformation of healthcare. We'll look at the video. Thank you.
Childress, Texas is a rural community of about 6,000 people. We're geographically isolated, so we're 100 miles from about 6 different larger tertiary care centers. Childress Regional Medical Center is a 39-bed rural hospital. We have about 250 employees, and when it comes to most healthcare services in Childress County, we're the only provider. So we serve a very rural, isolated, poor population of patients. When a patient gets a cancer diagnosis, that's tough no matter where you live. When you're 100 miles from care, it's even worse, and it had been a dream of ours for a long time to provide some sort of local treatment option for our patients. Low volume was a problem, so we're never going to have volumes that would justify a standalone cancer program. We needed a partner. It was actually the 1115 waiver that created that new relationship between Childress Regional, Texas Tech, the medical school, UMC, and the Cancer Center. Historically, our predominant referral patterns were to other towns, but when we met the folks in Lubbock at UMC, they were the first partner to say, what you're talking about is what we can do and what we need to be doing for the region. So we've been providing local chemotherapy services to a small number of patients on a limited basis for almost a year and a half. It was the waiver that connected the dots for us and made a local treatment option possible. I'm thankful for that because we are changing the outcome for our patients. We're changing lives.
I'm Chris Haig. I live in Crowell, Ford County. My wife and I, we run a small art studio here in Crowell in which we concentrate on doing canvas pictures and customized picture frames. May in 2013, I just finished bringing in the hay crop and I felt very, very tired. And so I went to the hospital to get a blood test, and they said my blood, I had a third of the amount of blood that I should have in me. And they did a colonoscopy and found a tumor in me. And at that point, I had to go through surgeries. Dallas is a 4-hour drive back one way, so it's 8 hours back and forth. Driving that far for care can be just really traumatic on your injuries. And every bump in the road you can feel when you go over it, and you're just completely exhausted. And it was just a horrific thing to have to travel that far to try to get treatment. When you come into Childress, they have brand new chairs and brand new equipment. They have a very knowledgeable nurse. They bring in a doctor that's probably one of the best oncologists I've ever met. John Henderson took us around and showed us the whole hospital and, give us his cell phone number to call him anytime he needs his help. And people get to know you, they care about you. You walk in, they can tell if you're sick. Now I'm in remission. I credit first thing God, and then the knowledge and the compassion that the doctors have given me, and also the compassion that John and the doctors and UMC has provided me with the skills and the nurses and the medicines to just make everything actually work.
In rural Texas, there are things we just can't quite do without a little bit of help. The waiver has allowed us to find new partners, to build what I think is a viable pilot program for cancer care in rural parts of Texas, and we are so much better when we find ways to work together.
the statement, there are certain things we can't do without a little bit of help, really is one of the most powerful things I think that is said in that video. As we think about, if you could help me advance the slide if you can, please. If we think about the future of the waiver and we think about the future of transforming systems of care, we're going to hear from our panelists who are going to share a little bit about their experience. And what you're not going to hear is a dissertation, if you will, on the project. They're not going to come up and give you, these are the metrics, these are the milestones, this is where we are, this was our obstacle, but they're going to talk about their projects more in a very systematic approach, because individual projects within hospital systems or healthcare systems or physician practices are only one part of it. It's how they interact with the community and the other projects and other initiatives in a certain area. When we think of the future systems of care, three things really stick out. The integrated system that Dr. Raymer talked about really cannot be measured unless you talk about the social determinants of healthcare. It's that honey bun. Where is the food source, as he mentioned? That was a perfect example. It is cheaper sometimes for us to eat unhealthy than it is to eat healthy. And how do we help our populations overcome some of those barriers? Transportation, a huge issue that we've all been talking about and trying to address. And then home life, shelter, those types of things are very critical. Collaboration doesn't just exist in DSRIP projects, but it exists because of DSRIP projects. And if you think about the Childress story, that is not a DSRIP project. It is the result of a DSRIP project. It is that collaboration precisely. And then lastly, I don't think we can talk about the future of healthcare and the future of transforming systems without keeping in mind the triple aim. If IHI, triple aim really says to improve patient experience, improve health of populations, and reduce the per capita cost of healthcare. That second bullet says improving health of populations. I think that what Dr. Raymer mentioned about population health and our understanding and being comfortable with it, I think that in some time, the IHI model of the triple aim of healthcare may need to put population in each of those bullets, because it really is improving the patient experience for a population, just as it is reducing the healthcare cost for that population as well. So some things to think about. I'm going to ask Allison Glendinning-Napoli to come up. She is the Director of Outpatient Care for the University of Texas Medical Branch, and she has 2 waiver projects at UTMB, and is going to talk about how the care navigation really has impacted overall performance. Allison?
Hi, everyone. Thank you for having me today and to let me tell you a little bit about our projects. So the UTMB Community Health Program system of care is a coordinated patient-centered care. As you've already heard today, and I'm sure you'll continue to hear in many of the presentations at this conference, UTMB identified a need. We identified that there had been an increase in health system use and higher readmission rates in patients with chronic disease, and that these rates were higher in the uninsured and in the underinsured population. So that information, combined with an understanding that 90% of chronic disease management occurs outside of the traditional health system encounter, UTMB developed a system of patient-centered coordinated care that guides the patient wherever they are in the continuum of care. And I liked what Dr. Raymer said about not just the continuum of care, but the communities of care. The interventions of our project or our system typically begin in the acute care setting. Our care managers connect with patients while they're in the hospital or in the emergency department prior to discharge. The purpose being is that it connects them instantly with someone who's going to follow them once they get out of the acute care setting. It also helps to determine potential barriers to a successful discharge and identify the patient's immediate post-discharge needs and their goals for what's going to happen when they leave the acute care setting. We continue to follow the patients at home with a focus on identification and teaching of red flags that may indicate they're having a problem that could send them back to acute care, medication acquisition, medication reconciliation, access to follow-up visits with providers, and the performing of a complete assessment, including not only their medical and health needs, but a complete psychosocial assessment as well. Follow up with continued additional home visits, accompany them to clinic visits, telephone follow-ups, again, providing that care wherever they may be within the continuum of care. Keeping the patient at the center, we provide education on disease self-management, health system navigation, and community resources. And we do all of that in a fairly intensive fashion, averaging about 4 encounters per patient per month. So to put this in a little better perspective, I want to tell you about Mary. Mary is a patient that I'm sure many of you have seen a Mary in the work that you do. Mary is a 64-year-old diabetic who had been in and out of the emergency department with severe hyperglycemia. She reported that she'd been sick for years, but she didn't really understand what was wrong with her. In addition, she had faced some difficult, life-changing personal events that had taken a toll on Mary, and as she reported, she was pretty much confined to her home. So we visited Mary at home after an ED visit and began working with her to understand her disease. This is Mary. This is Mary and Vicky. She's one of our nurse care managers. I would be remiss not to mention that also there's Jocelyn, the community health worker, Sarah, the social worker, and of course Dr. Mercantant, all working together in a collaborative fashion to provide Mary the care she needed to meet her goals. Her goals weren't extreme. She had a very simple goal. She wanted to get back to living her life the best way she could live it. Together, they did just that. Today, Mary has her diabetes under control. She's reduced her need for medication. She's lost weight. She's joined a support group. And she hasn't been to the emergency department in almost a year. Mary says she's living her life again. Mary's just one story. There are many of them out there, as I'm sure you are all aware. The impact of the system reaches wide, and in the aggregate of the patients that we've seen in our program, 55% of our patients have improved their blood pressure, 67% have improved their hemoglobin A1C levels. 36% of those who had no primary care provider have been able to establish care within 30 days, and in total 55% within 90 days. Considering that approximately 75% of these patients are uninsured, I think those are pretty good statistics. We've also been able to realize a 23% reduction in inpatient utilization and a 17% reduction in overall health system costs. So in summary, we're striving for the triple aim. We have demonstrated improved efficiencies in care coordination among internal and external entities, improved access to care for low-income, uninsured, and underinsured patients, achieved improved clinical and health outcomes, improved utilization and cost of care outcomes. And in conclusion, the waiver DSRIP projects have been the catalyst for UTMB to conduct a system-wide review of care management. We are currently finalizing the development of an interdisciplinary care model for patient-centered care management, care coordination, and transitions of care across our organization. And I think that that's been one of the one of the best things, not only for our organization, but for the patients that our organization serves. They will be the ultimate beneficiaries of this. Thank you.
Thank you, Allison, and we'll reserve a little bit of time at the end for some follow-up questions. It is now my pleasure to introduce Dr. Mark Hernandez, the Chief Medical Officer for Community Care Collaborative with Seton Healthcare Family.
Sorry, I got to set a timer for myself. For those of you who know me, I have a penchant for talking too much. I'm going to try to not do that this morning. Thanks for having me. I want to talk to you a little bit about the Community Care Collaborative and how we're trying to transform healthcare in Travis County. And a first thought for you, this is a quote from a movie. Change is hard because people overestimate the value of what they have and underestimate the value of what they may gain by giving that up. And I think that's a particularly apt quote for the work that we've done, because all of you out there who have been doing DSRIP work for the last almost 4 years, soon to be 5 years, know that really what you are is a change agent. That's really your work. You have different titles and you go to work and may not think of yourself as a change agent, but what we're actually trying to do is change substantially the way we deliver health care to our populations. And that has been your uphill climb. So it's not that you haven't come up with good ideas, it's that you are not necessarily empowered to implement your good ideas without some change in other people's work. And that's the trick, because everybody who's doing work, even if they recognize that the work they're doing isn't achieving the results they want, becomes somewhat wedded to a process, and they don't necessarily want to change it. And our jobs have been to tell people there is a better way to deliver health care. There is a better way for us to do this work, but it's going to require us all to change the way we do it. And that's always been the rub. That's certainly been what we've discovered. So what is the Community Care Collaborative? We're a not-for-profit healthcare organization that was formed in Travis County as a collaboration between a large not-for-profit healthcare company, Seton Healthcare Family, and Central Health, which is also known as the Travis County Healthcare District. It is the hospital district, so to speak, for Travis County. And these two entities had historically been responsible for the healthcare of the indigent in Travis County. There's a long history which I won't tell here. But essentially, these two entities have been responsible for the healthcare of the indigent. And there have been many other organizations that have contributed in different ways, but these have been the entities that at the end of the day, one of these entities had to come forward and essentially pay and or deliver the care that the indigent needed in Travis County. Well, that has led to a problem. When you have two people responsible for something or two organizations responsible for something, really, who's responsible for it? And that setup has been a challenging one for Travis County for a good long time. So these two entities came together and said, look, since we're both on the hook here, we're both trying to do the same work, why don't we actually become partners as opposed to just being two entities trying to be engaged in the same work? And so they came together and they created the not-for-profit known as the Community Care Collaborative. Now what's interesting about us as an organization is we got formed right during the period of time in which DSRIP was growing up. And so as DSRIP was coming up, this conversation was occurring. And so the DSRIP projects that we, the collaborative, perform, and that's about 15 projects that we do, are also in coordination with another 19 or so projects that Seton Healthcare Family is performing. There was always a notion from the beginning that what we were trying to achieve, particularly in Travis County, was a complete transformation in the way we deliver care to the Medicaid and uninsured and low-income individuals. And that we wanted some amount of coordination amongst the performing providers. That this wasn't, 3 different performing providers all choosing projects that they thought were the most valuable ones, kind of in silos away from the other providers. I wish sometimes, I'm envious of my colleagues down in Galveston, because down in Galveston, UTMB, they have a lot of centralization of all of this work under their umbrella. And there are lots of advantages to that, and I'm envious that they get to do that. In Travis County, it's very disseminated. There are various organizations that provide the care and various organizations that fund the care. What we knew was we had to bring people together and create a convening organization. And in large part, that's what the CCC serves. We're really no different than everybody else. We're trying to achieve the triple aim for our population. We believe to do this, to actually be able to perform high-quality care to our populations, to improve those population outcomes, you're going to have system integration. And DSRIP wasn't necessarily set up to provide a lot of the infrastructure that you needed for system integration. So we had to do some things to get around that. Obviously, we all want cost-effective care. That's a key part of this, and DSRIP is both a funding vehicle, the ability to bring new funds into our catchment so that we could use those to help transform care, but the projects themselves could contribute to the transformation of healthcare delivery. And that was a key element of our strategy. And then lastly, person-centered care. How do we make sure that we don't, in our eagerness to transform the system, forget that there's a patient there? Has always been a focus for us. This is just a slide on the burning platform for Travis County, though frankly, I don't think it's much different than any of yours. So I think every county and every region could put up a similar slide of their percentage of uninsured and how many of those people live under a certain poverty level. And I offer this data as our issues, but they're really all of our issues. And what do we need to do? All the things we've talked about. How do we create the effective and efficient care that we need by, one, quit doing things that don't work and do more of the things that work? How do you bring evidence to play in the care delivery? How do you provide those non-clinical services that are necessary, like patient navigation, like care coordination? It's not about figuring out what dose of a medicine to give the patient. It's about figuring out how to make sure the patient can get to the pharmacy and get it. And they can pay for it once they arrive. How are we going to measure it? So if we don't measure it, we don't know if we've made any progress. And these are just some of the essential elements. One of the key things that we've wanted to focus on in Travis County that I'll just highlight here, one is we have a big investment and dedication to creation of a patient-centered medical home model throughout all of our primary care sites. In fact, it is one of our DSRIP projects, that we would get all of our federally qualified health center sites, which perform 95% of the primary care to our population, up to the level 3 certification by NCQA. The other thing is that amongst all these other things here that you guys are doing is we believe there has to be some commitment, and in our integrated delivery system plan it lives there, for looking towards a future health promotion. So I don't question the notion that we have to manage chronically ill people now. We do have to do that. There's good reasons why we have to do that. But even if I get really, really efficient at managing our diabetic patients, more keep coming. So what are we doing to actually get ahead of the fact that we grow diabetics really well in the state of Texas, and that the flow of diabetics downstream doesn't seem to be slowing? So yes, we do have to get very efficient at managing that, but somewhere we've got to get upstream and slow the flow. If we're going to deliver to our physicians and healthcare system of the future a better system than they have today. I'm going to conclude my comments there. Thanks.
Thank you, Dr. Hernandez. I'd like to now ask Dawn Ziegler to come up. Dawn is the Executive Director for Access and Integration at JPS Health Network.
So I hope you've had this moment with your project where you took a step back, you took a deep breath, and you realized we really are transforming a system. That moment for me with my patient navigation program came when I was in Washington, D.C. at an event called EMS on the Hill. And I look out, and there's folks from all the states across the country that are coming to learn about what our organization is doing in partnership with our local EMS. And then the next day, they were going to their legislatures, and they were going to campaign for these kind of programs. Texas is in such a rare situation. The same thing happened with my homeless program. Over and over and over, I get opportunities to talk to folks about what we do with our Care Connections program. When I went to a Healthcare for the Homeless conference I kept hearing a common theme. There's a lot of folks with wonderful hearts that serve the homeless, but their one barrier was working with that darn hospital, getting the data from the hospital, coordinating care, and I stepped back and I went, wait a minute, I am the hospital. This is really great. And so we have a really unique opportunity in our community to transform kind of a microsystem with our most complex, our most sick, mentally ill patients that have the biggest amount of challenges. If we can be successful with this population, we can take those tenets and apply them to the broader group. So I'm going to show you kind of a crazy little screen, but it explains the program in a nutshell. Oops. At the top is a Cypress Clinic. This clinic, we had the best of intentions. We were located right across the street from the shelters. Great, you'd think the homeless folks would use it. But what we found was 50 to 60% of the patients were not homeless. They were coming there for primary care. So as we delved into that, we said, why? One was they thought they had to have benefits. They thought the emergency room was the only place they could go to get care. And truly, I can do 19 visits in my clinic for the cost of one emergency room visit. So I want to open those doors broadly. I want to make sure that my folks that are just outside those doors know how to get in. We had limited walk-in appointments, so everything was on a schedule. And if you don't know where you're going to sleep tonight, you don't know where you're going to go to the bathroom, you don't know where your next meal's coming from, you're not thinking about your primary care appointment next week at 3 o'clock. You're just not. So we had to change our paradigm. We weren't there to serve our schedule. We were there to serve our patients. And then we found eligibility can be a barrier, so we said it doesn't matter. If you have Medicaid, if you moved into town, if you haven't gone through our charity care program, come in, we will serve you. We've removed those barriers. So the next level is the shelters. So these are the guys right across the street. So I have all these folks. This is crazy. It's a crazy situation. I have 2,000 people at any given time right outside my door. Highly transient population. So about 30% of the folks are homeless about 30 days. There's another, I think it's roughly 20% that are homeless a year or more. So you constantly have a churn of folks coming in and out that don't know how to navigate the system. And then shelter check-in times. We had a high occurrence of 911 calls when folks would come to the shelters. Either A, they didn't get a bed, B, they didn't get what they wanted, C, they had a medical issue that wasn't dealt with during the day. And so we realized we had a real opportunity to partner with our EMS provider, provide some community paramedicine, as well as embed a nurse into the shelters. So in the bottom, you see all my hordes of people. Where are they going? They're going to the emergency room. We had to remove the barriers in primary care setting. I thought I was going to be hanging out in the emergency room. I got an emergency room outcome, but I didn't. I had to basically open those doors on the outside to improve the ambulatory care sensitive condition use on the inside. So how did we do this? It was not one thing. When we started, we thought this was an outreach team. And the truth was, if we didn't adapt our clinical practices, if we didn't adapt the whole system, we would be marginally affected. So we adapted our clinic practices. We had a new provider, wonderful man, 30 years in private practice, Harvard educated, left his fancy office to come work in my trailer because he was passionate about what we're doing. We adapted the PCMH practices. We actually achieved level 3 certification, which we didn't know we'd be able to do. So we took those practices and said, okay, this is a best practice to call your patients in advance. Well, guess what? I can't call my patients in advance, right? So we utilize our outreach team in conjunction with the clinic to reach out to folks. We utilize their case managers that are in the shelters to reach out to folks and work together for care coordination. The next step was to deploy outreach. So we can no longer think about healthcare as a fixed structure. This is our opportunity to bring healthcare to people and meet them where they are. And these are folks that would never engage in a system. They would be afraid to come in the hospital. They would only go to the emergency room, and there's a lot of fear involved. So we hired a physician assistant from Salt Lake City who does street medicine. And he literally will meet people in bars. He'll meet people in hotel rooms. He'll meet them where they are to provide that care. We also don't want to duplicate. We've got lots of people doing outreach in our community. We've got a wonderful community. So it didn't make sense for me to send a doctor or a nurse with other outreach services. It made more sense for me to educate my community partners on what we can do. And so we coordinate care with all of them. It's very exciting to get those calls and go, hey, this person, we need your help. That never, ever, ever happened before DSRIP. And then we coordinate outreach care with our clinic and also our partners. So we get together and have a conversation with VA, with housing, with other folks that we never really talked to before. Care coordination, integration. I love this. So we hired a community health worker. He was in a tent for 10 years. This was my first hire at JPS. They didn't know who I was. I said, can I hire a homeless man with a record? Because he wants to reach his own community. And so he's joined us. He rounds daily with patients while they're in the bed. So at this point, they're off their substances. At this point, they're in crisis. And we know from working with folks in crisis, you have an opportunity to pivot. So we really try and build that bridge while they're in the bed. We educate our own folks. We had a thing called the Amazing Race, and we discharged social workers, nurses, folks from other hospitals to the shelter and gave them different scenarios. So you have an O2 tank, which nobody takes. You have crutches. You have got discharged at 4 o'clock, but shelter check-in time was at 2. And they had to go ride the bus. They had to go through the whole process of walking in the shoes of our patients. You can't take for granted somebody's got a place to go. And that was the lesson there. We also are working on ED-based transitional care coordination, and that's kind of spanning a lot of our programs. Now next, we're evolving to a new clinic. We will do a lot more walk-in access. We do a lot of nurse visits. We try and find innovative ways to increase access. A lot of times somebody just needs that support. A clinical pharmacist we're going to integrate in our new facility. We're also integrating our case management, medical case management, with social service case management, adding additional staffing and then medication. Medication is such an issue. Talk to your patients. We learned something very troubling. We brought all our seizure guys in, brought them lunch, and we said, tell us what goes on when you're homeless and you have seizures. One man shared with us, they know that I seize. People on the street know, so they punch me in the head, and then they take my medications, and I seize. How heartbreaking for us to know what could save them is damaging them. So how do we better dispense medications on a daily basis to help support these guys being healthy? So on top of DSRIP, we had this wonderful thing that happened in our community. We are building a $10 million resource center. And this isn't just about physical health. This is about vocation rehabilitation. This is about social service integration. And so we had a wonderful man leave a foundation, and so this is rolled perfectly into DSRIP. And we now have an opportunity to take that team-centered approach at a community level. Thank you.
Thank you. I'd like to ask Landon Sturvant to come up. He's the Chief Operating Officer for West Texas Centers.
Thank you very much. This is a pleasure, and it's very exciting to see how passionate everybody is about the projects and around the room as you walk through, so, and especially the panelists. Thank y'all. My passion has been working in rural behavioral health, and I've been doing that for approximately 30 years. And I work for West Texas Centers for MHMR. We're a very rural community behavioral health center. We serve 23 counties. There's about 25,000 square miles. You know, from one side of our service area to the other is a little over 325 miles. It represents 11% of the landmass of Texas. We have less than 1% of the population in the state, but our service area is larger than 10 states within the United States. So the persons that live in West Texas deserve the same level of health care as those individuals who live in the metropolitan areas or other parts of the nation. The state of Texas is a very large and diverse area, and I think sometimes we have to look at what may work in Galveston or Houston or in Dallas and think about those things need to be modified somehow to meet the local community needs. And I think that's where the DSRIP projects have really come home, so that we can come back and see what our local needs are to meet those local address those local needs. West Texas Centers has 15 mental health centers scattered throughout the 23 counties. We serve a little over 2,500 to 3,000 persons per month. We operate in 4 RHPs. So I think we have 10 projects right now, DSRIP projects. It's been quite a challenge sometime when you're trying to coordinate across 4 RHPs, but one of our projects has been our telemedicine project, and it's been a real challenge to us as well. You know, you look at telemedicine and you think about the old TV show Green Acres and the guy crawling up the telephone pole to go talk to his doctor and stuff. You know, telephones have been around since 1879. We've been doing telehealth since back for a long time, so it's nothing new. In our area, we have some real challenges. Frankly, we have no private psychiatrist. We have no private psychiatric hospitals. There's only a handful of licensed behavioral health providers throughout the 23 counties. So when we're looking at this, there is no public transportation. So this has been a real challenge. When the West Texas Center started, our goal was to try to meet our local community needs and by taking those clinics out to those local areas. When I first started out there, I had a couple of doctors working for me. Most of them were pretty much approaching the retirement or coming out of retirement. They'd hop in their little airplane and they'd fly from one clinic to another. And so we would lose a lot of time. So one of the solutions, this was back in 2000, we went after a telecommunications grant and we were awarded our first telemedicine equipment. We really didn't know what to do with it. It was this great big $40,000 box sit in the corner. And, you know, we thought, well, we could start doing this and we could bring physician services so our doc wouldn't have to get in his airplane and fly from one clinic to another. Well, it took us a long time because we didn't have the other systems in place to do that. And that's where we came up and looked at one of our DSRIP projects was our telemedicine expansion. One of the first things we saw we had to do was expand our network connectivity. Frankly, many of our areas cell phones don't work. There is one provider of telecommunication services in the area, and you're fighting with everybody else in that area for that bandwidth. We had to look at how we can move away from having to buy those $40,000 monolith telecommunications pieces of equipment that were the size of a refrigerator, because that just would not work in the local ER, the jail, or, you know, plus our community partners couldn't afford to go drop out $40,000 for a piece of equipment. So we invested part of our project, DSRIP project, was in some elements of purchasing hardware so we could make it easier for our community partners to basically get a laptop, pick up their cell phone, and be able to provide services or at least have a consult without, no matter where they were. If they had internet access, they could go through our secure network and provide that. The other thing we did was looking at was how can we increase the access to care? If I'm having my doctor spend 50% of their time driving up and down the highway to go from one location to the other, 50% of the time is not spent serving the patients who are in need. So it was just a real challenge. With the implementation of our DSRIP projects, we have now developed a system of care that is not just across West Texas or Texas, it's across the nation. The stars on the map here that you look at are locations where I've had a provider that's worked for us that's provided telemedicine services to the individuals in rural West Texas. You know, you look at there's actually a star in Hawaii. The doctor that worked for me the psychiatrist who worked for me out in Hawaii did a great job. The time zone difference was a little bit of a challenge. It was definitely hard for him to get up that early in the morning. But as you look, most of our providers are basically east of I-35. And, you know, we have partnered with UTMB, we've partnered with various other entities. But the aspect this brings to the table is that we can look much larger than just our little communities of West Texas, of, you know, the 3,000 population here and so forth. Some of the benefits that we have seen through the use of our telemedicine project, we have eliminated our waiting list. We had over 200 persons waiting for acute or intensive treatment for chronic mental illness. And these were individuals who were out there, were not doing well. We've expanded services to our local jails. A large percent of the population who has chronic persistent mental illness are focused, their treatment ends up being in the jails. And when you look at the small communities out there, they don't have the psychiatrists. There's not a psychiatrist. That wasn't part of my presentation, by the way. You're not hearing voices. But another thing we've been able to do is open access. We've been able to have a process of getting the persons who are wanting or requesting our services in immediately. When we first started this project, we had a mechanism of bringing somebody in to get them to see a licensed clinician, and that took about 2 weeks, and then it was about another 4, 6, 8 weeks before they could get them in front of the psychiatrist. Through the use of telemedicine and our program, we've been able to take that down to about 2 weeks. That's not our goal. Our goal is we want them in within 1 week of seeing the psychiatrist, or the same day, and we're looking at how we can do that. As a real-life example, I got a call the other day from one of our small communities. It was the hospital, and they had a gentleman in there that was acutely psychotic. The local physician was saying, "I don't know what to do. I'm putting this person into the intensive care unit," because there was no bed, no local hospital bed. Well, through the use of telemedicine and providing a consult, we were able to help that local community, help that individual not have to go into the intensive care unit, get the psychiatric care through the telemedicine, and the person actually went home with medications and support system. Well, there's a number of other areas that you can see are our next steps. We hope to go forward, contracting with the managed care companies to pay for more of the services, expanding it into our ERs. But one of the things I wanted to close with is telemedicine is today's reality. This was a doctor's visit by telephone in 1962. So we've been working on this for a long time. So thank you all very much.
Thank you much. And our last presenter, representing the Rural and Community Health Institute, College of Medicine, Texas A&M Health Science Center, is Carla Blaine, and again, Brazos Valley Post-Discharge Care Coordination Program.
Good morning. Thank you very much. I'll try and make this so we don't run over too much and go into everybody's time. But the Brazos Valley Post-Discharge Care Coordination is a navigation program that we focused on ED diversion and getting our individuals contacted with primary care in our community. We found that, as we all know, too many are using the emergency room for their primary care, and they're not really getting what they need on a consistent basis. Our program is not associated with any hospital or large health system. We had to develop a really large system of care within our community because that's what we had available to use. We found that a lot of our individuals, when they left the ED, went back to their communities, which the area around College Station is very rural. We have a lot of cotton and cattle in the 7 counties that surround us. So they get back to their community and not have what they needed. They ended up back in the ER, and as we know, the ER is not the best place to manage your chronic condition. The program we have operates by receiving referrals from the local EDs in our community. Those individuals have been flagged as using their ED inappropriately for non-emergent purposes, and they've reported that they don't have a primary care provider, so they send them to our program. We have state-certified community health workers. We assign each one of our clients a health worker to help them navigate. We get them connected with a clinic in the area, get their primary care services, whether it be dental or medical, or behavioral health. We often find that their problem may not be medical in nature, so we try and get them where they need to go. And then we also work with them on those basic issues that keep them focused on health care. The community health workers will get them connected with a source for a supply of their medication or equipment, to the local food bank. We know all the schedules and bus routes for everything. Transportation is appropriate. And our community health workers are fluent in Spanish. That's the alternate language that we find most needed in in our area. And as you can see from our diagram, we are focused on being very client-centered, clients in the middle. We do an assessment. We try and find out what they need. Our first area we branch out into in that next level is their medical, behavioral health, dental, the more health-related need. And then we branch out into our larger circle, which is our community resources. And that's where our big system of care comes from. Because we're not clinical, because we're not associated with a clinic or hospital, what we do is we know how to get people in our community connected with what they need. So we built our system of care on relationships within our community and to really focus on that collaboration. Such as we have an arrangement with our local free clinic that gives us 2 appointments a day on their schedule. So we don't have to call them. We know we have those appointments, and when we have someone that we need to get seen right away, we can plug them into those appointments. Our local FQHC helps with dental issues. We can get them in there. We also applied to a grant proposal with our local Rotary Club, and they awarded us a small grant so we can get people in emergently. The FQAC can help folks on a more maintenance and regular basis, but to get an appointment with them, they're so stressed, it can be 4 to 6 weeks. So with this little grant we got from the Rotary Club, we can get people into a private dentist, be able to pay for an emergent tooth extraction or something that keeps them from going back to the ED over and over again for a dental issue that the ED can't really help them with. We work with the Brazos Valley Council of Governments that has an office that helps people with housing issues. Other organizations in the community that can help us get our clients what they need. So we really are kind of in that center of the cog, planning them out and working in that source of care. We find, though, when it comes to monetary issues, again, we're not a hospital system or a large health hospital, so we don't have necessarily a clinic that we can plug somebody into or a place to send them. And when we have a need for funds and money, we've actually developed relationships with our faith-based organizations in the community. Salvation Army, St. Vincent de Paul, and a lot of our local churches have really pitched in when we needed to help someone pay rent or pay a utility bill. We had one local church has a real nice youth group, and they actually did fundraisers and developed funds. They bought bus tickets and donated them to us so that we could get our clients bus tickets to get them to and from their doctor's visits or appointments to the Medicaid office or whatever we needed to do, because many of them don't have a way to get back and forth across town. We're able to connect them with information on their chronic illnesses. We try and empower them into their own care, getting them to those appointments, calling them and reminding them about appointments, how to communicate with their healthcare providers, what questions to ask. Be sure and take the log of your blood pressure readings that you've had. If you don't have a blood pressure cuff, maybe for your birthday present, maybe your cousin will buy you it makes a great gift if you need one, a blood pressure cuff. Or a glucose monitor, because those are the kinds of things that we all often cost money and our program doesn't actually have for. But we've been able to find ways and places and people to help out. So we have a really big system, and it falls back to the term about taking a village and a system, because it really does. Not any one, even our community partners, they can't necessarily handle everything that an individual does. So by working together, we're meeting all of those needs. In one case, we had a gentleman who was working part-time. He was diabetic, missing a lot of work because he was going to the ED, not getting his meds, not managing his diabetes. We got him into a primary care provider, got his diabetes under control, so he was missing a lot less time at work, had less sick time, and eventually the employer, with his improved attendance, hired him on full-time, and he got health insurance. So he was one of our great graduates of the program. Another client we helped was a Medicaid client. He was disabled. He'd been on traditional Medicaid for quite some time. He got switched over to one of the managed Medicare programs, but didn't quite understand the implications in his care for that process. So while talking to him, he admitted to us he's only taking his insulin once a day instead of 3 times a day. And when we asked why, he said, well, the pharmacy says Medicaid won't pay for my syringes anymore. Well, yes, they're not going to pay the pharmacy, but we knew that his managed care organization would cover that for him. So we contacted the PCP, got a prescription, found out who the supplier was for that designated MCO, because they all have their own suppliers, got that prescription faxed, and now he gets his syringes mailed to him on a monthly basis, and he's taking his insulin like he's supposed to, so he's not going to the emergency department. So even though he already had a PCP, we didn't necessarily do that part of the plan, but we've gotten him out of the emergency room, and we still got him the care he needed, getting the correct syringes. It's just a different aspect of what we do. Another interesting case, a client was Spanish-speaking only. When he left the emergency room, they had made arrangements for him to see a urologist. He could pay an amount, so they got a discounted rate for him. He got to the visit. Neither the doctor or the staff spoke Spanish, so he left. There was nothing he could do. Went back to the emergency room. That's how he got to our program. Our community health workers go with him to his appointments now. They do all his translation. And for most of our clients, we call and remind them when they have an appointment coming up. But in his case, he now calls us to remind us that he's got an appointment next week, and he wants to make sure his community health worker is going to be going with him to that appointment. So our system has, we're small, like I said, we're not part of a big group, but we have a really good community, and that community has made a big difference in getting our patients everything they need and access to care. Thank you.
Thank you, Carla. Can I have another round of applause for the great panel? I like to do my best to be a rule follower, so I know we're at the end of our scheduled time, but with that said, I do think that before we introduce a quick video that'll take us, I guess, into the lunch session or the next session, I would like to just encourage each of you, though we didn't have time for the question and answer portion today, over the next day, we have the rest of today and then tomorrow, to please seek out and connect with folks on the panel. I think that our friends at HHSC, Lisa and Ardaz and their wonderful staff have really listened to us as anchors and also to providers. Many of you, I know, for example, in our region and many of the others, we went to you last year and said, hey, what did you like about the conference? What did you think could have been done better? And what would you like to see next year in order to really get the most out of it? And one of the biggest things that we heard, and it wasn't just from Region 2 or Region 6 or Region 9, but it was really almost every region saying we want time to connect. We want time to really delve into each other's projects. And I think that becomes some of our most valuable time. For example, in Galveston, Allison has entertained, I think, at least 5 or 6 organizations representing probably at least 3 or 4 regions that have come and shadowed her community health worker program. That is a great example of this collaboration, to see what we're doing and then how we're learning from each other. So with that, I would like to introduce a video on Washington County EMS, and Washington County EMS program is in Region 17. So we ask you to focus on the screens, and thank you so much for being part of this session today. Thank you, panel.
As soon as the call comes in, the paramedics hit the road. Randy Armstrong knows how to deal with heart attacks, strokes, but now he's learning how to handle non-emergencies.
Look at the patient's overall social picture.
It's through Blinn College's community paramedic program.
So we're going out in the community contacting, say, our frequent flyer patients that call us multiple times out of the year, and hopefully we can offset their use of the 911 system.
Meaning more home health care checks, like making sure they keep up with their medication.
Find them and help them educate themselves on their chronic disease management process to maybe keep them out of the hospital longer.
In 2011, close to 400 patients called several times for non-emergencies.
So that's 20% of our call volume. So if we just focus on that 20% and we can reduce that number, it keeps us from having to add more paramedics to our crew.
Washington County EMS is the first in Texas to try this approach, and only the 4th in the country. It's an innovative attempt to decrease healthcare costs.
It's about $400,000 to add one paramedic ambulance to a community. So if this year we didn't add a crew, we actually added ACP providers to go out and find that 20% call volume and decrease it.
Though this type of healthcare is ideal in rural communities.
I do think it's the future of paramedicine, and it's something that we can do that directly offsets healthcare dollars.
Washington County EMS estimated it could save $1.2 million within the county through the Advanced Community Paramedics Program. In Brenham, Monica Castro, KAGS HD News.
I'm Rebecca with HHSC. I'm so glad you're here. I've got a couple of housekeeping notes before we all take a break. Lunch will be served at the tables, so this is a full flight. If you have a seat that's empty beside you, please remove your stuff from it so that somebody who's at the periphery can come join you at your table. Make new friends and collaborate. So otherwise, we would like for you to move your items into your chair so that we can get lunches put out. Thank you.